Bismillah, alhamdulillah, wa salatu ala rasulillah. Thank you, Chairman and Co-Chairman, and thank you to the organizing committee for inviting me to share this interesting session. The non-surgical management of benign thyroid nodule, we are been using for the last 5 to 6 years. The radiofrequency now comes to the market, the microwave ablation. This unique organ that controls a lot of the metabolism and functionality in the body, and it's usually a multidisciplinary approach on such a cases that we do. So we always have on board the endocrinologist, the interventional radiologist, and also the head and neck surgeons. Clinical assessment is very important. Even if I get or recruit a patient who comes to me, to my clinic, it will go through the endocrinologist to be seen in the first time, and then we will assess thyroid gland examination. Ultrasound is the most important exam to evaluate the thyroid. Still, you can do thyroid scan and all the blood investigation that can be. What are the non-surgical approach or treatment? We used to do a lot of ethanol ablation, not anymore. Nowadays, it's wearing out after the radiofrequency ablation had came out. And it can be done for the cystic and the non-cystic also. And laser is one of the things, but I have no experience on that. Now we are doing more of the microwave ablation. Now, the most important thing and the most crucial is the inclusion criteria. Now, older than 18, it's not restricted to be that, but sometimes you can get a younger ager group, like 16 or so on, so they have to be evaluated. Mainly solid, as we can see here in the images, or it could be semi-solid, which is a mix of a component. And usually you have to aspirate the cyst completely if you're planning to do anything to those patients, whether you're doing the FNA or to proceed for the procedure itself. Now, by looking at ultrasound, there are criteria, and usually they go into the TIRAD classification, and the TIRAD is, I'm not going to go through it, but you can evaluate either malignant or benign nodule according to what it looks like, the echogenicity, and how wide or wider than taller and the opposite. Like the malignant one usually does not respect the organs next to it, so they go more speculated with an absence of a halo sign, unlike the other one, which is the benign. So in evaluation of the echogenic texture, either it's a cystic purely, or it's microcystic, which can be a spongy form, or it could be a solid. The macrocalcification is an important thing to evaluate as well, which could be an intranodular or perinodular, or it could be a mix of the two, as we can see in those images. This is a very important one, which is the vascular pattern. For me, when I evaluate the cases, it tells me when I am doing the radiofrequency ablation, the higher the vascularity, the higher the watts into it. Now, the benign nodule, this is a well-established that we have to do it in contact with the cytologist. At the same time, the recall that we have in our center is almost zero. So we get all those patients in one day, and then I do the FNA myself for all my patients who I'm going to do radiofrequency ablation. We always fall into the category of 2, which is Bethesda 2, and that's the most important part. We don't do any of 1 or 3 or 4 or 5 or 6. Now, in some center, they always say hot on sonography, no FNA. I still do FNA in all my cases, even if it has been done. The volume is very important. It evaluates to you what you need to, if the volume is larger than 25 mil, that you probably have to tell your patient that you're going to do it in 2 sessions. So evaluation of the volume and also the measurements. All this test and all the investigation is done by the endocrinologist, and they will prepare the patient, and we always discuss the cases, and the patient will be followed up as well by the endocrinologist, and the endocrine surgeon also share some of his, if the patient is needed to go for surgery. Now, some of those patients, they come to you, they already have some problem with their voice as pressure symptoms. We know that the pressure symptoms either swallowing or breathing or also the voice. I always evaluate with an ultrasound, as you can see, the vocal cord pre and post radiofrequency ablation. This is very important to know if there is any problem. Now, if you look at the right side of the screen, that's a normal vocal cord movement. And then in this patient, you could see the thinning and the right vocal cord paralysis. And this can be, most of those patients, it will be a transit. It might not last more than few weeks or sometime during the procedure itself, and you have to be ready to do a hydrodissection, we call dextrose, also giving a hydrocortisone as well. So the diameter is important. So to evaluate all the diameter in 3, and I usually do see the patient in the clinic, do it before also the procedure, and also another third ultrasound will be done to be documented. Now, there are patients who you require to do a CT scan because of the extension of the nodule itself, which could be a retrosternal, and to evaluate the entire organ of the thyroid. Now, there are some exclusion criteria like pregnancy, and as I said, in the Bethesda, or it could be, it's always evaluated prior to the procedure. This is a very important chart. The thyroid nodule, pressure symptoms, either yes or no, or calcitonin less than PG, 3 PG per ml. It is the TSH less than or equal, less than or more than 1. So if it is less than 1, iodide thyroid nuclear imaging or hyperfunctioning nodule. But then you go for the ultrasound where there are pressure symptoms and evaluate by the TIRADS accordingly, and then they will go for the fine needle aspiration, mainly Bethesda 2, and the treatment option for that will be either active surveillance as discussed with the endocrinologist, or it go for surgery. You always have to give your patient all their options and to know what is better for the treatment. Thermal ablation, radiofrequency, and the treatment option for the other one, either a surgery or iodine-131, or also radiofrequency or combined together. So pre-procedure preparation is important to evaluate with the ultrasound, with the color Doppler, with the gray scales, and to assess the entire thyroid. We usually do 1 nodule at a time, depending on the size. This is the setup of the machine itself, which is, this is the only probably machine available in our country, in Saudi Arabia, which is this RF Medical, and it has 2 sizes of needles. One is 10 centimeter with an active tip of 1 centimeter, and the 7 centimeter active tip is half centimeter, and they range between 18 and 19 gauge. So it's all in one box. Very important to do also an isolation for the radio frequency itself, while in microwave is not required to do that. So blood testing, sedation, sometime I give my patient conscious sedation. Local anesthetic is very important. Sometimes you can lose the voice while you're giving the sedation. So be prepared to have your 5% dextrose ready to do the hydrodissection. I don't do normally the hydrodissection unless I evaluated the borders and looking at the vagus nerve and also the recurrent laryngeal nerve, which are very important, and specialized RFA electrodes and could be monitored under ultrasound. Usually patient is supine. The access can be transascium or lateral approach, but most of the time is from the center, depending on the neck and the size of this. Anatomy is very important things to do, and they used to call it a danger zone or the triangular zone, but I will go into the criteria of that, where you can see the vagus nerve, where it's usually sitting between the carotid and the jugular, and it does not take color when you do a Doppler ultrasound. This is the difference between the two. We used to talk about the danger triangle, which is very a triangle between the groove of the trachea and the esophagus and the medial portion of the thyroid, while the danger zone will occupy more because of the descent and the recurrent laryngeal nerve changes in position inferiorly, and that's the one which is sometimes difficult to localize or to see. That's how I set up. I sit in the head of the patients, and that's how it's done. The first thing is local anesthesia. As you can see here in the video, that you have to do it on the capsule itself. So you will infiltrate all this area, and some of it will dissect also and make a hydrodissection by itself. Placement of the needle is only one single puncture. No incision is made, only a single puncture, and I move up and down while doing it. If you look at this one, I'm sorry, the image, when we place them, it goes into the side. So this is how it moves. You usually move from down of the nodule up to higher level and to occupy all of the nodules. Sometimes I start from the top and I go to the bottom, because on patient with a large nodule aiming to do a second session, that I have to bring them back again. That's what it looks like when you're doing the procedure itself and your movement of your needle, and you accordingly starting your watt from 20 and you go on. You can go up to probably, I have gone up to 80. You're allowed to go to 120, but you have to be careful on that. So in those patients, you can see the significant reduction in the first patient on the top, but those patients, they will have a second session because of the enlargement. It's more than 5 or 6 centimeter. So as you can see in one of the images, that it will become hypoechoic in general. And then I usually don't send them to the ultrasonographer at all. I keep managing my patient for the first 3 months to 6 months, because they will give you the wrong interpretation every time they see it. So this is how we set up. Usually I do it in a bigger room with all the team with us, and the monitor is very important. This is where you see the watts and the timing and the impedance as well. So it's a 20, temperature has to be below 20. So as you can see, the temperature on the screen is about 5, and not to exceed 20 minutes of doing the RFA. This is a patient of 39, female, with left thyroid nodule, and the time, it was 3.8 by 3.2 centimeter during RFAT. In a follow-up, if you get 3 months post-RFAT, it has reduced 2.1 to 1.5, which is about 50% reduction. And here we can see, this is 2 weeks follow-up, the one on the top, and then follow-up after 6 months, where there is a significant reduction of the nodule itself, and also they improve in their symptoms. Now, we have started doing a thyroid ablation. If you look at this patient, the right side picture, where the trachea is really compressed. It's not a nodule, it's only enlargement of the thyroid. She is non-surgical candidate, so you can embolize one of the arteries. There are 2 arteries in each side. So if we are going to embolize thyroid both, we have to embolize only 3 and leave 1, so they don't get hypothyroidism. And this is at the end of this. This patient has improved significantly, that she was not able to really do breathing, and you could hear the sound. Her daughter called me 2 days later, and she told me, this is the first time I can sleep next to my mother. Thyroid nodule radiofrequency ablation, major complication ranging between 3.8 in large systemic reviews, and there has been a lot of study for such cases. Also, this is one of the first trials that has been done on North America, where they concluded that our worker first analysis comparing benign and intermediate thyroid nodule, and suggest RFA be promising modality for the management of intermediate thyroid nodule. Also, in such cases, we can see the significant reduction in the period between 6 months and 4 months. It can reach up to 93% with a less complication counted. Also, some of the centers, they use ultrasound contrast study, which they think that it is a better imaging to evaluate. So if we look at surgery and we look at RFA, both options have to be given to the patient, very important, and has to be discussed. You should discuss the RFA as an expert, and you should leave the surgery for the head and neck surgeon or the endocrine to discuss it. It's a single treatment available for intermediate, for indeterminate nodule, risk of hypothyroidism, scar, general anesthesia, only 1 FNA, while the other one is local anesthetic, 2 FNA biopsies, multiple session, maybe if it's more than 6 or 7 centimeter, available only for benign nodule, and preserve the thyroid function. So in general, it's either follow up at a low surveillance or a high surveillance, and then you can follow up your patient, even if it's small nodule. Even you have to reassure your patients. Or they can go operative as surgery, or the selection of RFA, or the microwave. Now, this is the take-home message of tips and tricks. The power used depends on the user. So usually in the beginning, a lot of people, they should start with the 20 watts and they go on. But it's always a 10-second increment that you can increase the watts. The duration is about 20 minutes and the machine will go off. So most of the cases we do is range between like 5 and 12 minutes or so on. So it depends how you do it, and how, you know, with time. Ice packing is very important, 10 minutes every hour after the procedure, and it should not be directed into the skin. The cystic nodule we will usually aspirate, and then we will ablate afterward. Hypervascular nodule, as I said, you have to have a higher power to compensate for heat sink effect. And as I said, if it's larger than 4 centimeters, probably you will have to warn the patient that you will be doing it in 2 sessions, not only in one. As I said earlier, from deep to shallow, and ablate the feeding vessel. I usually ablate it last. Seriously, you can look at it and evaluate it in the beginning. Some people, they do it before, and some people will do it at the end. So this is a non-invasive procedure, and keep your thyroid, no scar, reserve thyroid function. This is, we still in the process of publishing some of our data. This is entirely in about 10 centers in the kingdom. We have done about 1,934. I have gone to about 600 so far myself. This is a minimally invasive treatment. They're very low risk, and there is none of the reported patient experienced any life-threatening complication related. Even a lot of people, they get scared from the voice, that it has changed, but it doesn't last long. this is a good message from one of my patients that sent thanks to Allah, the procedure only a tiny dot and minimal pain, while the pain from the IV cannula is worse than the procedure itself. Thank you very much. This is my contact, and anybody can scan it from there, from the audience, that you will get all the information required. Thank you very much.